Good afternoon. Welcome to Medical Grand Rounds. I'm Bob Wachter, Chair of the Department of Medicine. I think everybody kind of knows the ground rules by now, but closed captioning is available. CME is available if you're interested to stay on at the end, and there'll be a web address to claim CME credits as well as a barcode to take you to the right place. Please type any questions you have in the Q&A box. We'll try to get to as many as we can at the end. This is another in our regular series of Grand Rounds. We'll be back to doing a COVID Grand Rounds next week, probably an update from the Infectious Disease Society meeting that is occurring right now. We'll have some of our folks who are attending the meeting to give us an update on what they're seeing at a national and international level from that conference. Very excited about today's conference, both because the topic is interesting and pretty new and dynamic, and we have two of our leaders relatively newly recruited to UCSF who have really transformed the way we think about critical care cardiology. If you think about it, one of the improvements in clinical medicine over the past 2 decades has been a deepening understanding of the role of systems of care in ensuring timely, high quality, safe, effective, equitable care. And one of the aspects of systems that we've discovered is the importance of teams. And that may seem like a no-brainer, but it really is only over the past decade or two that we have had things like rapid response teams and palliative care teams and stroke teams and pulmonary embolism teams, really born of a recognition that sometimes you need to aggregate all of the right people from multiple disciplines to address a complex problem, and particularly a time-sensitive complex problem. One of the latest, and I think most important examples of this is the shock team, a relatively new intervention that, and quite new for us at UCSF, that does all that, brings together the right people at the right place with the right expertise to not only deliver excellent, timely patient care, but to think about the work as a systems problem. And today's discussion will be about these kinds of these shock teams, how they're organized, what the rationale is, and how well they work. And some of it will be on how it's actually working at UCSF. So I'm thrilled to introduce our two speakers. One is Chris Barnett, who's professor of medicine in the Division of Cardiology here at UCSF Health. He's chief of the section of Critical Care Cardiology and medical director of the Cardiac Intensive Care Unit and of Inpatient Cardiology. Chris studies disease processes that happen in complex heart disease in the ICU, including, but not limited to, cardiogenic shock. He's interested in how to make care better and also to train future cardiologists and generalists in how to improve the quality of care in critical care cardiology. Chris earned his MD from Northwestern, did his residency at Northwestern, did a fellowship in critical care medicine at the National Institutes of Health, and a fellowship in cardiology at UCSD before joining our faculty just a year ago. And even in a year has made a tremendous difference in the care we deliver to these patients and also the training of fellows, house staff, students, and I venture to say many of our faculty as well in this area. So Chris, welcome. The next speaker, actually our first speaker, is Connor O'Brien. Connor is also relatively new to UCSF. He's assistant professor of medicine in the Division of Cardiology here at UCSF Health. He's a cardiologist with expertise in echocardiography as well as in critical care medicine, focuses on shock and severe cardiac dysfunction in the ICU, and also cares for patients and thinks about how to improve the transition from cardiac intensive care to out of the ICU and also to back home, and does research in the areas of improving the care of patients with severe cardiac dysfunction. Connor got his MD at Columbia and did his residency in medicine and fellowships in both cardiology and critical care medicine at Stanford before we wooed him here 2 years ago. So we're thrilled that he is with us as well. Among his honors include he was part of a national championship winning rugby team in 2006 and played on apparently the top rugby league in the USA, but does that on the side. So with that, we will turn to, I think, Connor first, Chris second, and then we'll be able to open up for Q&A. Connor, welcome aboard.
Thank you very much for that probably undeserved, kind, warm welcome. Thank you for the invitation to give Grand Rounds. It's really an honor for Chris and I to be here. This process and development shock teams is something we are both very passionate about, and many of the people on today's grand rounds have been contributors to both the execution of the team as well as patient care. We've been incredibly grateful for your collaboration, and it's been really a great process and ride to be part of. So thank you very much to all of you. And the title of today's talk is Shock Teams, the Jaws of Life for Cardiogenic Shock. We have, so Chris is on the ABIM Critical Care Medicine Exam Committee. I have no disclosures. So the reason I entitled this talk, The Jaws of Life, is the Jaws of Life is, this device that we've all heard about over the years, extricates motor vehicle accident victims from their vehicles. And when you see it, we very much focus on the tool, but the truth is it's actually a team that executes the utilization of this tool. And when you look at everybody involved here, they all have a very specific role. There's somebody operating the jaws of life. There's somebody caring for the patient, maintaining the C-collar, making sure the patient isn't burned, cut. There's somebody doing spark control on the ground and monitoring power delivery, somebody doing crowd control. If you look here on the right, in France, they do mobile ECMO. And this is an example of the ECMO team being activated in the subway. And here you can see it's far more than just a surgeon or a doctor. There are people doing crowd control, power management, lighting, all sorts. Somebody's got to be managing that subway car, making sure it's not moving. Really is a coordinated effort that is far beyond what meets the eye. And so understanding where the shock teams are born from, we got to look at the history of cardiology. Fortunately, in cardiology, there's a lot of data to draw on, and particularly in ACS and cardiogenic shock, which is where a lot of the initial attention and shock was drawn. So looking at just the curve of survival in ACS over time, going back to the 60s, this is Desmond Julian, who designed one of the first CCUs, the Royal Infirmary, and it was really designed to provide early defibrillation to patients. So they cohorted patients who had heart attacks, monitored for VTVF, and shocked them as early as they could. And you can see over the first 10 years, there's a little bit of a drop in mortality with ACS. And this is Thomas Killip, who designed the Killip class. And one of the really important advents that he got credit for developing the Killip class and identifying high-risk patients. But what most people don't know is he is credited for operationalizing the nursing team to deliver early defibrillation and empowering them to act early for these sick patients. And as these teams became more efficient, better at identification, and more people were empowered to act and work together, you see an improvement in ACS outcomes over this next 20 years. Then you start to see the real improvements that we realize today with anticoagulants, lytics, PCI, and this takes ACS down to its mortality that we all enjoy today, seeing our patients do really well with this 2 to 3, maybe 4% mortality. Overlying that, if you look at the mortality in cardiogenic shock, it's far higher and has been much harder to improve outcomes. The Gusto, you can see this in the shock trial where PCI was first studied in shock, was one of the first trials to show that early PCI improved 30-day outcomes in patients with ACS and cardiogenic shock. And then over the next 10 years, similar to that early improvement in the 60s and 70s, what you see is a steep reduction in mortality in cardiogenic shock, and mostly from AMI. And a lot of that comes in from improved systems intervention. So EMS having better notification systems, mobile monitoring technology, and then hospital systems being able to activate the cath lab and really operationalizing so that we could realize the full benefits of PCI. But then we hit a nadir, and all sorts of tools and MCS devices, medications, inotropes are developed over this next 20 years. And here, IVP shock, which was the routine use of balloon pump in cardiogenic shock, failed to show any benefit from the routine use of balloon pump. And this started to get people guessing, saying, why are we having this inability to improve outcomes in cardiogenic shock? And same thing this is another representation of some of the primary data, and that you can see that here the expansion of PCI led to improved mortality early on, and then outcomes really stabilized. Some people sort of infer that this tail here from 2014 to 18, maybe some devices, but the trials really failed to support that. And so there is some signs of improvement here from 2015 to 18, which is the first consistent downtrend in that curve. And we're going to talk a lot about what might be driving that data. Here we go. So looking and saying, why are outcomes not improving in that time? And looking at a lot of the primary data that really looking at the tools that we use, I think is important, because we use inotropes, we use MCS, and a lot of us who do this day to day really feel that these tools are essential to improving outcomes. But the tools, when they're studied in trials, have all really failed to show benefit and often cause harm. So in OpTime, this is a study looking at milrinone for people with heart failure and the initiation of long-term milrinone use, especially at highlighting that lower curve there, which is milrinone used in ischemic cardiomyopathy seems to dramatically worsen outcomes. IABP shock, which is the comparison of balloon pump to traditional medical therapy for patients post-MI in cardiogenic shock, failed to show any benefit. Impress is Impella compared to balloon pump and similarly failed to show any benefit. And importantly, Impellas, they really show improvements in cardiac output, filling pressures, but that doesn't translate into outcomes. And it's really important to ask why. So just going back to the trials that we've talked about in these early trials, saying what were the definitions of cardiogenic shock and what could be potentially be done better. Initially, you look at the systolic blood pressure below 90, the wedge is above 15, cardiac index lower than 2.2, pulmonary congestion, and then physical exam findings and data that can often take some time to collect. And that sets the backdrop for trials that have high diagnostic requirements to recognize that these patients are experiencing what they're experiencing. The diagnostics that are required to get that data are often difficult to utilize. They require a certain amount of expertise. They're not necessarily widely available. And there's also been some data conflicting on the utility of pulmonary artery catheters as routine use that has led to them being underutilized. So we're set up in a situation where you want to try to improve outcomes, but we're being a bit hamstrung by the modalities available to identify these patients. Also happening simultaneously, cardiogenic shock is an evolving physiology. The number of causes has expanded dramatically over the last 20 years, not causes, but the recognized causes. And it's really a broad range of physiology. And every one of these tools is designed to treat a very specific physiology. So if you start lumping a whole bunch of different patients into a category studying a tool that's designed to treat a small fraction, it's not surprising that we have a lot of treatment failures. And also then there's a lot of changes in the backdrop of these patients, where a lot of these patients have more chronic disease than they did previously. And if you look just over time, the number of patients that are coming in cardiogenic shock in the last 20 years, ACS is now a minority driver. It's really not a very small fraction of what we see. And the patients tend to do better because systems are in place to treat them better. And then also there's a lot of medicines and good doctors out working out in the field who are in providers just broadly who are bringing down blood pressure, keeping cholesterol under control, public health interventions are minimizing smoking. And our patient population is changing because of that. And in that backdrop, despite all these public health interventions, the incidence of cardiogenic shock is rising fairly dramatically in the last 20 years. Some of this is due to an aging patient population. You can see here our patients are getting older. A lot of patients they're being treated better outside of the hospital, and so, or more efficiently, I should say, and that means that they're surviving longer with their disease. So we have more of them to treat, which is a good problem for both patient and us. We like that. But they also show up with more multi-system failure, and there's rising requirements for mechanical ventilation, renal replacement therapy, because living with these diseases takes a toll on your body. And here is a representation of primary admitting diagnoses to CICUs over a 10-year period from Medicare data. And I really would highlight that if you look at the primary cardiac diagnosis or the driver of admission, less than 50% in the latest cohort of this patient or this sample was primary cardiac diagnoses. There's a huge expansion in infectious drivers of admission, neurologic complications, and other things that really need to be considered when we're dealing with shock. This is from 2019. We're members of this Critical Care Cardiology Trial Network, and they provided some epidemiology data for CICU admissions from 40 academic centers and all tertiary medical centers. But the patients that make up the CICU now, about 22% of them are cardiogenic shock patients. Mortality is around 31 to 39%, so very consistent with those numbers we showed previously. Interestingly, LV failure is under 50% of the drivers. Large fraction is bi-V failure. There's an increasingly recognized fraction of isolated RV failure. Some of that's pulmonary hypertension, which is a very exciting, expanding field that Chris has been part of. And in addition, I highlight that primary cardiac cause unrelated to pump function is 20%. So a lot of these patients will be missed on a bedside echo, and LVEF is greater than 50% in 10 to 20% of this population. Again, so if we're using LVEF on a quick bedside echo is one of the ways we recognize these patients early in the ER, we stand to miss the opportunity to intervene for a lot of these people early on. So the big questions in our field is, how do we do better? How do we get the correct therapy? Trying to making sure that we use a multimodal diagnostic evaluation, that we efficiently use all the tools that at our disposal early, that we seek multidisciplinary input. Anytime you have an aging patient population with multi-organ dysfunction, it's very likely that you're going to have to call your neurologist, you're going to have to call your surgeons, your nephrologists, and really get them to help you think about, how do we optimize this patient's outcomes? It's not just about saving their heart. A lot of time we can replace the heart. We really got to save all these other organs or not expose these other organs to danger. And then really importantly, everything we do requires continuous evaluation. There's risk and downsides to everything we place. So we have to think about, how do we build teams that constantly reassess that risk benefit calculation, make sure we're doing the right thing minute to minute, day to day. Picking correct patients. We have aging patient populations, and the world is very much, and with more precise medicine, we all have experts now for gerontologists or people who are helping us do the right thing for patients and keep their bodies safe, and making sure that we're going to think about their body in context of where they are. There's also high rates of cardiac arrest, which is its own separate variable that we really need to think about, independent of the rest of shock. And we'll share some data that helps our guide thinking there. And then also correct timing. How do we, signal for all early intervention tends to be better all across most critical care medicine, whether it be antibiotics, PCI, almost always the signal shows that the biggest bang for your buck is when you get the correct therapy in place as early as possible. So how do we facilitate getting that done? And we're also improving complication rates. So this is something that's very near and dear to my heart. We use a lot of these experimental tools, and we are all very focused on, the or trying to mitigate these really high complication rates that may be part of the reason we don't see benefit from the tools we use. And that requires the providers to be very thoughtful. This comes in where shock teams come in. So, and to do all of this well, as I just outlined, it's not any one person who can really deliver optimal care in this scenario. Team members from most shock teams include cardiac intensivists, heart failure cardiologists helping us think about what are our ways we get out for patients, what can we offer them, interventional cardiologist, cardiac surgeon helping us with the support tools, and then a very specialized nursing staff that knows how to use these tools properly and make sure the patients are safe while they're the ones sitting at bedside after we put it in, who take care of these patients for weeks to months and making sure the device stays safe that entire time. So optimizing patient capture. This is one of the biggest things that has been achieved, I think, in the last few years. Some of the early trials when they wanted to sort of figure out, how do we better capture these patients? How do we get away from this need to identify a cardiac index less than 2.2, for example? Some of the early trials, what they did is they simplified the diagnostic criteria for notification of the shock team. And this is one of the algorithms used from Inova from their from their first trials published in 2019. I just want to highlight very quickly that systolic blood pressure that is falling out of favor, but we'll talk about that later. But they removed a lot of communication barriers. They created 24-hour coverage, a dedicated phone or pager, and they simplified the eligibility criteria. And then they went out and they tried to educate all the providers in the hospital and say, hey, here is some of the features of cardiogenic shock that are a little bit different from other types of shock, and maybe we should be thinking about it earlier. Call us and we can help you think through it. We want to be part of this early thought process so that we can be involved and execute our workflow early. So the shock teams, they are also, once they start getting more notifications, really have to optimize patient selection. These are very resource intensive pathways, and patients are extremely complicated. So we want to make sure, or the providers want to make sure that they're doing the right thing for these patients. You want to identify patients who are otherwise terminally ill, have relative contraindications to some of the things we may need to do. A lot of this is center specific, so it requires a lot of collaboration within the center to talk about what are going to be some of our age cutoffs. A lot of this is driven by transplant age cutoffs, VAD age cutoffs, then constantly integrating scientific data as it becomes available to you. So this is data that came out of the AHA that showed outcomes for patients presenting after an arrest. And you can see that survival and pulse and favorable neurological outcomes for pulseless VT, the outcomes are quite good, whereas PEA is a lot different and asystole is even worse. And if you overlay that with duration of CPR, we have some fairly robust data that guides thinking in this field to help say which of these patients need how much support. And then also for patients, if you went through a lot of thinking, maybe if there's opportunity to improve care, maybe it says we're under supporting some of these patients and maybe we need to be more aggressive early. And then in addition, the other thing shock teams very much go through is we work with proceduralists. So we have to learn how they think, because if we're at bedside and we're going to want to introduce some therapy very quickly, i.e. ECMO or an Impella, we have to identify vascular access issues, patients at bleeding risk, and patients with intracranial bleeds, because most of these patients are going to be anticoagulated. And if you want your proceduralist to be successful and be able to move quickly, you want to do as much of the thinking and the work that you can to screen in these patients for appropriate care at their initial screening visit, or at bedside, I should say. The other big part of this is, and for the residents on this call who have been on CICU rounds with us, we harp on this all the time. There's a lot of education going out in phenotyping cardiogenic shock. We still want to emphasize that people think about early ischemia, because that's something that's a very well-defined pathway. While we're doing new teams, we don't want to reinvent parts that are already working. So still making sure we're doing our EKGs and thinking about if we need to get patients in the cath lab. But once we've ruled that out, thinking about getting our pulmonary artery catheters in quickly, using bedside echoes, and really to identify some of these numbers, trying to see if can we estimate cardiac output, filling pressures in both ventricles to help us understand the affected ventricle, to help dictate which kind of support modalities we'll pursue. And then also some diagnostic criteria. We'll talk about some of these hemodynamic parameters that help us predict outcome. Another thing that is catching a lot of attention now is this cardiometabolic assessment, or a hemometabolic assessment. It is with more recent terms and more contemporary terms. And what it shows, if you look in the top right there, this is some data from an AI initiative where they looked at a lot of patients and tried to phenotype cardiogenic shock by non-congested, cardiorenal, and cardiometabolic. And importantly, if you look at that, the blue and green diagram up there in the left next to the survival curves, what that's showing is that the cardiometabolic group is associated with a lot of systemic congestion from RV failure. And that might be just representing more systemic failure, like that's causing global compromised cardiac function, or you just have more profound cardiogenic shock. But it's identifying patients at really high risk for mortality that need really profound and significant interventions early. And below is some of the variables that are associated with each of these phenotypes. So starting to really be comprehensive beyond just our filling pressures and output, thinking about our patients as we really need to preserve end organ function. That's what we're trying to save here, thinking beyond the heart. So once we do all of our assessment, then thinking about early revascularization or early institution of MCS if it's appropriate. Our echo assessment, we've moved far beyond just EF, and some of the things that we try to teach pretty broadly now is the LVOT VTI, which is surrogate for stroke volume. You can do the same thing on the RV side. It's a Doppler metric that can help you estimate stroke volume, from which you can estimate cardiac output, and there are limitations, but it can be very helpful, especially for patients who have a normal EF, but a very low cardiac output for a lot of your restrictive patients. We also look at specific RV measures like RVS prime and TAPSE. We look at size, because that can help us dictate what kind of tools we can fit in the ventricle. And then for anybody with chronic disease or akinesis, we really want to rule out thrombus before we move forward, because we can drive strokes by dislodging that if we put the wrong tools into the ventricle. We also do a valvular assessment to make sure that to see what the valves can accommodate, and really looking for regurgitant lesions, because each of these can offer limitations to mechanical support, but also opportunities for medical therapy that might help us avoid medical or mechanical support, particularly for MR. So some of the hemodynamic assessments that we do, we are looking for, we put the numbers that we get into some of these metrics like cardiac power. And this is data generated from the shock trial and has subsequently been revalidated. Cardiac power, we multiply MAP times cardiac output and divide it by a 451, which is a constant. And here on the top right, you can see a survival curve showing that lower cardiac outputs have a very significant association with mortality once you get below 0.53. Different institutions and studies have found different cutoffs, so that you'll see some different numbers, but usually it's around 0.6. Most of the recommendations are hovering around there, but showing that there's really a huge increase in mortality. And I personally really like cardiac power because it not just integrates your cardiac output, but a lot of our patients get inappropriately vasoplegic, and it brings in the blood pressure to say, do you have enough cardiac output adequate to support your need for perfusion? So it's really a little bit more complex than just looking at what the heart is doing. It says, can the heart meet systemic demand? There are more nuanced assessments we can go for different ventricles. The PA pulsatility index is one that's commonly used for the right ventricle. And there are cutoffs for different physiologies. Right ventricular failure needs to be thought about differently between pulmonary hypertension and LVAD implantation. So just cautioning people with the numbers that you will see in each study and really make sure it's tailored to your patient. But PA systolic minus diastolic divided by CVP is meant to describe the step up in pressure happening in your pulmonary artery, which infers RV function, and how strong that RV muscle is. And that helps us guide whether or not we need univentricular support, RV support, biventricular support. Similarly, the CVP to wedge ratio is a similar description of BiV dysfunction versus LV dysfunction. The last thing we pay attention to is we put all of these metrics in context of our patient's ideal body weight and BMI, because as we want to escalate or see how hard can we make this heart work, we really need to think, is this enough for our patient's body? We really need to make sure that we're doing the right thing. If we're going to do it early, we got to hit certain numbers and make sure we're making metrics. When we go up to our device selection, assuming we get through our workflow and medical therapy doesn't seem like it's going to be adequate, these are some of the tools that we use. On the far left, there's balloon pump. I know most of us are a little bit more familiar with this than the others. That's a balloon that it inflates during diastole to drive blood up towards the brain and down and back towards the coronaries. And then it goes down during systole, creating a reduction in perceived SVR by the heart. And we'll talk about that a little bit later. But really importantly, the balloon pump itself doesn't really pull blood out of the heart. The amount of forward flow is very, very minimal, which is part of the reason it probably has failed in shock trials to really improve outcomes. Impella is a transvalvular device that goes into the femoral artery and is advanced over the aortic valve into the left ventricle, and it pulls blood out into the aorta and directly offloads the left ventricle. The tandem heart is similar, that it offloads the left ventricle, but it goes up through a femoral vein. And it's a little bit more difficult to place because you have to place it over the septum. And so it requires a septal puncture and pulls blood out of the left atrium. And the blood goes through a rotor that is then re-injected back into the descending aorta. The disadvantage here, and we'll get to this in ECMO, is you have blood being shot back towards the heart, which creates afterload and creates work for the heart. RV support, this is on the right it's traditionally called a Protec, but it was purchased by Tandem. So you'll hear the two names used interchangeably. This device pulls blood out of the SVC or right atrium and then goes back through this rotor, and it shoots the blood antegrade into the pulmonary artery. The RP Impella works similar to the left-sided Impella, but it pulls blood out of the RA and shoots it directly into the pulmonary artery. So it never moves out of the body like the Protec. And then there's ECMO, and this is our tried and true where you pull blood out of the vein and shoot it right back into the artery. But again, really important to remember that you are shooting blood back towards the ventricle, creating afterload, which creates work. So once we picked our device, one part of the back end of the shock team that not as many people have exposure to, We really try to protocolize, and all this is not just us at UCSF, but all these teams have thought a lot about this. How do we protocolize care to keep patients safe? So there are routine use of imaging to assure position is stable. Hemolysis and platelet counts are monitored daily or twice daily. Perfusion markers and end-organ markers are cycled at least twice a day, usually Q6 up front, to make sure that we're perfusing adequately. We're constantly monitoring preload and afterload to not just rely on the device, but to minimize work for the heart, to give the heart time to recover while we're using the device to see what we're going to need to do next. And then there's also daily assessments for de-escalation of support and possible bridging therapies that are lower risk and allow our patients to ambulate and continue to recover. So this is some of the initial shock team performance that was done by some of the innovators in the field, most of these trials were all done around the same time between 2015 and 2018. And I will not go through each of these, but in all three trials, a cohort of patients was identified from 2 years preceding the initiation of the shock team, which makes it a very comparable cohort. There were not any instances of new technologies introduced at these centers. Most of the providers who were part of the teams were there pre and post advent or rollout of the shock team. And one of the very interesting things that I saw that I take away from these three trials is that the improvement in survival is almost identical across three. And the starting point of mortality is almost identical across all three. So you see this where most centers land around 70% to 75% survival in the cohort, which is improved from a traditional 40% mortality. Some of the common themes in these trials from the University of Utah, there was a lot more transfer on MCS, which may a lot of referring centers may be moving earlier, and also might represent some educational efforts done by the hub center. There's a lot less balloon pump use pre and or post after the rollout of the trial. You see a lot more advanced therapy and escalation away from balloon pump, recognizing a lot of the patients that need or that are being inadequately supported as part of this daily check and perfusion monitoring. Additionally, on the right here, this is a little bit different study, but I like to highlight it. This is a Detroit Shock Initiative, and what it shows is that this was an intervention, people monitoring the use of whether or not Impella used pre or post PCI was better associated with outcomes. And what you see during the trial, after an interval assessment, a lot of providers started to implant Impellas earlier, but also importantly, also using PA catheters earlier. So a lot of this what you see here is outcomes were improved with earlier introduction of therapy. The concept, or what I take away from it, is that providers are identifying shock patients earlier in their workflow. We always want to ask the question of, when you move away from trials, are you going to be able to generalize these findings? And mortality, this is a study that Chris did prior to coming to UCSF. And this is from the C3TN group, that large tertiary center group that about 40 centers that contribute to this database, and of which we're members. And in this study, they looked at centers within the cohort that have shock teams and compared them to those that do not. There are about 1,200 patients included in this analysis. And what they were able to show from 2017 to 2019, so a contemporary cohort, if you look over here on the right, centers without a shock team had a higher mortality in patients with cardiogenic shock. And centers that had a shock team had a higher rate of pulmonary artery catheter utilization, looking here on the left. The overall MCS use in the shock team centers was actually less, but the use of advanced MCS was higher. So more pointing to this as a general lesson that has been being learned across centers that are specializing in shock, is trying to focus on the right therapy for the right patient at the right time. And early introduction of diagnostics that help you make that decision may be associated with lower mortality. So we ask what could be some of the mechanisms behind this? Like, what are we really achieving? And there's been some early work done by this group at Tufts that has been studying mechanisms of potential improved outcome using Impella in STEMI. And just reviewing our pressure volume loops, you look here, this is a traditional pressure volume loop up in the top left, where you have early systolic or isovolumic contraction here, right? You have ejection, isovolumic filling, and then your pressures are going up through here. What you see is the impella, it shifts your curve to the left because it actively removes blood throughout diastole. So during this diastolic filling period here on the bottom, you don't achieve the same filling pressures in the LV, and you offload the work the left ventricle needs to do. This is an impella in action. This is a video taken from the Abiomed website. This is your inflow portion of the catheter down here in the ventricle, and blood is ejected directly out into the aorta through the outflow, and the motor housing is up here at the top of the catheter. So this, one of the studies that has been come out of this work is a pivotal trial that's now in a phase 3 trial where they are not performing PCI and LAD STEMIs, and they place an impella upon arrival, run the impella for 30 minutes to offload. And the concept is what they're trying to reduce is an accumulation of reactant oxygen species and minimize redox injury in myocardium. And then they perform PCI at 30 minutes after unloading. And what they showed is there's a big reduction in scar volume in these patients. And this was performed by cardiac MRI. There's no hard outcome benefit thus far, but it's a very provocative idea that there may be this relationship between unloading and reperfusion and minimization of scar. When they looked at this in a pig model that accompanied this study, what they were able to show here in electron micrographs is that the mitochondrial ultrastructure, and this is transvalvular unloading here in the middle, is preserved in these patients. And you have pure ischemic reperfusion here on the left, showing a lot of ultrastructural damage. And on the right, they had pigs run on ECMO. And these pigs had full blood pressure support, but you see a lot of ultrastructural changes. And remember that ECMO cannula is shooting blood directly back at the left ventricle. So even though it supports blood pressure, you are increasing the work that the heart does. And in the non-infarct zone here at the bottom, you can see there are no differences across all three of these groups. So again, not definitive, but provocative, thinking about, this period of rest may be essential to recovering myocardial function and really a big part of what we should be trying to achieve through shock teams. A lot of people always ask me, this is a constant question for members of shock team across the country, is the balloon pump dead? And one of the big things we say, maybe not, again, thinking about physiology, we really got to think about what the balloon pump can do, because it's a much lower risk tool than a lot of the other things that we use. So one of the big features, looking just here at this list of what the balloon pump achieves, there's a big reduction in afterload from the balloon pump. The increased LV stroke volume is just pure blood removed from the ventricle by that negative pressure is very, very minimal. And coronary perfusion increase is fairly trivial. That doesn't seem to be a big driver in most patients, or maybe select patients where that's true, but as a majority rule, unlikely. So some really interesting studies came out of Columbia, and they were able to show that in chronic heart failure, in retrospective studies, but that there was despite really low cardiac power index, this is an indexed value for rather than cardiac power, they showed a dramatically improved survival in these patients relative to traditional shock data. And what they were able to show is that patients who had chronic heart failure, a PAPI less than 2, and so looking at patients with who had good RVs, those were the patients at risk for deterioration. But patients with a high wedge and a strong high PAPI actually did better. And then when they restudied this group, what they found is that in acute decompensated heart failure compared to acute MI, there is a 5x higher rate of 5x increase in cardiac output augmentation compared to the AMI group. And so thinking back to the mechanisms of the device, if you have a patient who really benefits from that reduction in SVR, then this might be a very potent tool. And it might be a very potent tool, especially if somebody has an inappropriately low SVR state where you can't drop their blood pressure anymore, but the heart needs to see that negative pressure to get more improved output. So again, provocative ideas sort of anchoring us all thinking about the physiology for our patients. So just going back, looking at incidents of cardiogenic shock trends, of thinking about what has happened since or in these last 10 years. In this last 10 years, there's been a lot of improved recognition. There's been a lot of education. These shock teams data have been widely circulated. And so some of this you might be seeing that there's better education nationally leading to some of these inputs or thoughts that are driving improved outcomes. A lot of this national data we see at these same timelines, balloon pump utilization is dropping here. Advanced MCS use is increasing in those exact same time periods. So you're seeing a lot of centers starting to adopt these workflows and processes. Unfortunately, use is not ubiquitous. So, and I'll just highlight, in the interest of time in these slides, larger centers in cities and academic centers tend to be the centers that are using these devices. So they're not ubiquitously used. There's a lot of reasons for this, not just expertise. They're very expensive. It's difficult to monitor, and a lot of times you don't have the ancillary support to use them on the floor. There's also a lot of inter-hospital variation. The cost of these makes them very hard to use. What this dot plot shows is each of those is a hospital, and the likelihood of you getting the same device in the hospital is represented by the percent value on the left, which shows a lot of hospitals tend to use one device. So there's a lot of room for improvement. Also really want to highlight that, going back to the team theme, large centers that do high volumes of cases are where you tend to see these improved outcomes. And these improved outcomes don't just come from MCS and shock teams. When you look at all in multivariable analyses, what you find is that places that really have the best outcomes for patients with a cardiogenic shock, or at least on paper, it comes with a lot of other variables that drive that outcome. There's a lot of MCS, there's a lot of PCI, there's access to surgical expertise and early surgical expertise. So it's much more our job, or one of the jobs that shock teams tend to focus on, is making sure that we select patients that can benefit from the multimodality therapy that the hospital offers. So really, again, it takes a village. And so how do we do better? With all of these, how do we get this, with all this education and data coming out? And a lot of the efforts that have been started early is we don't even communicate well as to identifying the acuity of our patients. This is something that has been a big effort within the society, SCI, which is our interventional society. And they have developed a fairly robust scoring system that helps categorize shock. And in the interest of time, we're not going to go through each of these. But really what the point is, and you can see the colors bleed into each other, that we're trying to identify patients who are in the beginnings of shock and escalating periods of therapy, and then in extremis to help other providers understand what do we need to do to support this patient. And there's lots of robust data that is being analyzed showing that these are predictive of outcomes, and that when centers roll this out, that communication seems to be improving. Other opportunities for improvement, one in Chris's paper here on the left, the time from CICU admission to PAC placement was associated with improved outcomes. So the question is whether or not we should be doing things earlier and earlier diagnostics. Also, if you look at the use of pulmonary artery catheters in existing shock patients and another large cohort of patients, you can see, looking on the right, the number of patients, or the percentage of patients that got a complete assessment by a pulmonary artery catheter, is still impressively low. And this held true in this group, even in the really high stages of SCI shock, showing that we're still not fully utilizing a lot of it, or I should say, maybe not be utilizing a lot of the diagnostics available to us. And this is in that last image I showed, this is from that same study looking at a heart failure or a cardiogenic shock initiative, that the use of pulmonary artery catheters was associated with improved outcomes. If you look here on the bar graphs in the bottom right, and this effect was most pronounced in SCI shock stage D and E. And this has been shown again in some other studies. So it's very provocative thinking that maybe we should be rethinking our relationship with the pulmonary artery catheter. Another big challenge, and I know we struggle with this at UCSF, is thinking about how do we support people outside, and making sure that we help facilitate care. So creating relationships that allow patients to get into these centers quickly. And so this is an example of our diagram at UCSF. It's very busy. And I know I want to leave some time for Chris here. So I want to go through this because this is some of our internal data. And many of you have contributed to this. And it's really a success. We've been really excited about the outcomes. And looking here, you can see our SCI shock stage internally is very well distributed, but tends to be fairly high. Our rate of cardiac arrest in our cohort of 44 patients that we did, this was our first year of data, 2020 to 2021, was very, very high, which is normally associated with really poor outcomes. Our rate of MCS utilization is quite high, but implying there's a lot of coordination across teams. And our 30-day survival was 69%, even with this really high rate of utilization of ECMO and arrest. And our survival to discharge was 61%. If you look at our average lactates across group, Mayo is one of the gold standard studies of which a lot of places compare. Per Sky stage, our average lactates were a lot higher, and our rates of CPR were higher. And if you look at our survival by stage, we had very high survival up through stage D. And when you look at some of these patients in E, a lot of these were PEA arrests and people who had really, really poor expected outcomes. So we have been very excited by this data and been trying to share it with as many people as we can, not just to generate interest, but also so that everybody who's been involved can really share in celebrating these results, because it's the residents, fellows, nurses, our critical care colleagues, surgeons, our interventional colleagues. It's really taken a village to do this, and we've been very lucky to be part of it. So thank you all. And we'll skip this slide in order to get to Chris. Chris, you're muted.
So we missed the me thanking Connor for his outstanding presentation. We'll jump over that. I'm going to step back a tiny bit and just talk a little bit about teams in critical care medicine in general. This is a great review article, and Jesse Hall is the senior author here. It's really one of the giants in critical care medicine. And it's a fascinating paper because it reviews the fact that we don't really have any technological advancements. And this was granted 12 years ago, but I'd argue we're about in the same place. No technological advancements in critical care medicine. And really the things that we have are multidisciplinary team-based care, and it's the way that we deliver care that has changed. This paper goes on to talk about other things that have improved outcomes in critical care and includes things like hand washing, reducing infections. So it's really basic core things. And I think these are really important lessons from critical care medicine. And I would argue that this is what we learn in critical care fellowships, is how to work together. And these are what we need to bring to cardiology, how to work as a team and how to work in team-based care. Connor, in advance. So this is the classic no person is an island, and keep going. So we don't, yeah, there we go. So what I want to display here is that this is, we have a tradition in medicine and a tradition, I think, in cardiology of teaching people, our teaching philosophy is that people need to become independent practitioners. And I would argue that that's the wrong philosophy. And I think that especially in our space, in the CICU space, and I would also argue broader in cardiology, that in becoming an independent practitioner, it should no longer be the goal. The goal really should be becoming a practitioner who can function effectively as a member of a team, and that needs to be our teaching. Go ahead and advance. And this has been recognized in cardiology, increasingly recognized in cardiology for some time. So this is a paper back from about 2018. And I would argue that that cardiology, that team-based care in cardiology really is patient-centered care in cardiology. So when we talk about patient-centered care, when we talk about multidisciplinary teams, the reason to do this is because this improves patient care. Go ahead, next. I realize there are a couple of edits are different. I might have had a newer version. But this, I like this a lot because Tom Metcalf, who's the senior author, is a Hopkins critical care cardiologist. And it starts to, and this is an illustrative case series that's worth reading about other types of cardiac disease that for which team-based care is really important. Go ahead, Connor, next one. And then go ahead and click one more. There should be one other. There we go. And this has also made its way into cardiology guidelines. And so I think the question we have to ask ourselves is this the new standard in cardiology? And if that's the case, then we need to be teaching this as our standard of care, and we really need to be engaging this practice. And we find the same thing in outpatient cardiology here with this example of pulmonary hypertension clinics. Go on to the next one. Again, this is just another example. I pulled this example for pulmonary embolism, showing that team-based care likely improves outcomes. And this work has resulted in, go ahead, the next slide, the establishment of big international professional societies that are fully devoted to expanding team-based care in these different disease states. Go ahead, next. So I want to end on this because I think this is something really important. This is just a paper from a few months ago, and a particular interest of mine, and something that we're trying to develop at UCSF. But the question always is who belongs as part of the multidisciplinary team. And I think in critical care cardiology and in cardiology in general, this is one of the things that we currently don't have, that we're not talking about very much. And I'm hoping that at UCSF we'll be leaders in this, in incorporating palliative care specialists into our cardiology teams. And that's all I have.
So again, just want to say thank you to everybody. Richard Chang should get a special shout out on this. He did a lot of the heavy lifting the year before I arrived to educate people and get buy-in for the team. All the members of the team who are on here, we actually all took call for this, and it was separate from our service duties. And so all the names there really get a big shout out for taking this on to show that how important this is. Really a labor of love, and we couldn't do it without all the other names on here. Our surgical team, our support from leadership, and then on the bottom right, all the people. That's everybody. Those are all the groups of people that both get the patient in the hospital and provide daily care. And those are all large groups of people, including the residents and fellows, so many of whom are on this grand round. So thank you all.
Great. Thank you both for really fascinating discussion. And we'll open up to Q&A. If people have questions, please type them in the Q&A box. I'll start with a few. When I looked at the definition of when you folks get called, the majority of the patients that I see that look like that are septic. So, there was hypotension and lactate and all that. So what and you said that the majority of cardiac shock these days is not ACS, so it's other stuff. So I'm trying to figure out what the boundaries are between septic shock and cardiac shock. Obviously, other causes of shock will have an impact on the heart. The heart is a player. How do you think about that? And then Chris's last comment made me think, I can imagine a world where somebody is trying to figure out, do I call the PE team or the sepsis team or the cardiac team or the rapid response team? So sort of 9 teams bumping into each other in the room. How do we sort that out?
So our general ethos for this is, because we also have tried to launch a PERT which I'm part with Matt Aldrich, and we've been really focused on trying to be collaborative, recognizing there's a lot of overlap, and really trying to drop the barrier to activation. We don't want people to think, if you're wrong and you call us, we're not coming. We help with the PE response all the time, actually. Mm-hmm. We get called commonly for RV failure. And so we really want people to think to try to activate us early. There's also a lot of patients with mixed shock who have chronic heart disease and distributive shock, and their underlying cardiomyopathy or cardiovascular dysfunction precludes them from supporting their hemodynamic needs. Mm-hmm. And there's some evidence that's fairly convincing, again, retrospective, but early, showing that in mixed shock, ECMO support is actually quite effective. And a lot of people always talk about ECMO being ineffective in sepsis. And that's true if you need 20 liters of cardiac output and you have a normal heart and you're just hypotensive because you're so vasoplegic, there's just no way. But if you have mixed shock and somebody has, a cardiac output of 4 and an SVR of 400 and they just can't support it, it may actually be an option. And so I think it's worth, and nobody's really put their dime down on where the limits are of how we support these patients. So keeping
I get it. It's hard. I'm just trying to think about a resident on the wards today who walks into his or her patient's room and the patient is hypotensive, tachycardic, has a lactate, maybe has a low-grade fever, and says, "Well, I just heard this talk on shock team. Which team do I call?" Is that? And I don't think the cardiac is the primary player here. Although I'm guessing if I stuck a transducer on, I would find that the heart's not working perfectly well. So how does that person in the moment sort out who to call?
So this also comes to being collaborative and cross-training. So we cross-train a lot of the critical care fellows in ultrasound. So they actually function as an extension of our shock team, even though they're not necessarily formally members. Their bedside echoes help create or find the variables that decide whether or not we're needed. And they call us for further evaluation for PA catheter, cath, EKG review. So I think it's really getting everybody comfortable thinking about it, learning how to use the tools that are available to all of us in the hospital, which there's a million people contributing to educational efforts to make us all better. And then us reducing the barriers to call, just so that we don't get called too late. Say, just, if you have a question and we can help you think about it, we're here.
Great. Chris, do you want to add anything?
Yeah, I think Connor's right. And I think that a key to this is not waiting. And I understand the question of which team do you call. I think oftentimes there's a little bit of data that might be available to help, direct a first phone call. But as Connor said, a lot of folks who are involved in these teams, you decide the PERT team comes first because your patient's been hospitalized for 2 weeks. And it becomes the PERT team shows up and, there's a lot of smart people in the room and someone realizes the patient's more likely infected. I don't think there's any harm done. I think the harm is in not calling. And again, I think that the kind of the concept that we have to function alone, we have to figure things out by ourselves. I think that's a concept we have to get away from. And it's a calling for help. And there are a lot of teams of expert folks in the hospital who have access to a lot of resources who can help figure these things out. I say it's not uncommon that our team is called for patients who we, in the end up transitioning to comfort care. We, in the end up having an infection, and that's okay. And I think that there has to be trust in us also that we're going to be collaborative, productive members of the team. And that calling will not result in any, and this I think is true for all the teams in the hospital, is calling should not result in bad feelings. Like nobody should be upset on either side if someone calls the CICU team first because they think it's cardiogenic shock and we forgot the person's septic. That's great, and I think the patient wins because they've gotten a lot of attention, and I think that's what we focus on.
Got it. The old saw was that you don't start with mechanical devices unless it's a bridge to something. Are you changing? And it sounds like ACS is not so common a cause that it's a bridge to opening up your coronaries. So how are you thinking about the person who gets whatever the device that you decide is the right device is? Is it is it a standalone thing that then we can get them off it, or are you thinking about it as a bridge to something else?
So we think about it in terms of whether or not it can even just bridge to recovery. So just to give you an example, we had a 76-year-old patient the other day who had a lot of comorbidities, who probably had a rate-related myopathy because she had a decent amount of data as an outpatient, and there was a lot that we could write on that was fairly reliable, but she clearly needed ECMO. There were some missteps, and we said, we can probably recover her. It's a gamble because she's not going to be a candidate for other things, but we put her on. And she actually recovered in 4 days. We decannulated her and she ended up on heart failure therapy and did very well. So again, this is very nuanced, and we really got to think about every patient's physiology. But to that point, if you have a patient who's coming in as chronic heart failure, who's had heart failure for 20 years and has been increasingly symptomatic for a year, and they're not a candidate for VAD or transplant, putting MCS in place there is a bridge to nowhere. So that is an example. We do keep that in our mind. But we don't want to exclude patients who could benefit based on simple criteria. I sort of was trained in the generation when PA catheters went from all the rage, everybody needs one, to being, you're demonstrating you're a terrible doctor if you put in a PA catheter. Sounds like they're back in vogue. What do you think that's about? Like, what are they helping you do that you couldn't do before? Maybe Chris, you want to take that one?
Yeah, and I think this goes back to what Connor said earlier about, the original shock trial definition of shock was a systolic under 90, and we still talk about that a lot. And what we're recognizing is that is not the case all the time. There's a lot more. The whole SCAI shock classification tells us that shock is much more nuanced. It's not just defined by a blood pressure target. And I think as you said, I remember when I was in residency, also everyone got a PA catheter. It was like getting a pulse ox and a blood pressure, and that clearly was not a useful approach. I think now we're much more selective, but we put PA catheters in patients when we don't have information, when the information that we would obtain from that PA catheter is going to clarify the type of shock and how we're going to manage that patient. I think it's also important that we take these things out as soon as we don't need them. So we certainly don't put it in like a pulse ox, even in these complex shock patients, We put them in when they'll give us data that will change decision making, and we take them out when they're no longer useful.
Yeah.
So that remains a key.
Yeah. I'm surprised with all of the non-invasive stuff that we have, it still gives you so much incremental data that's useful. It sounds like it does.
Yeah. But one of the big issues with echo and things, like sometimes you just can't get the windows that you need. A lot of people advocate for use of echo, and a lot of time you spend a lot of time digging around for windows there. And one thing I'd like to really add, because this has been a hot debate when you read articles about PA catheters, a lot of people say maybe the benefit from PA catheters you're seeing in all these studies is because people who are not going to benefit, who are going to pass away, are the ones who don't get them. And there's actually been studies directly working on that to keep an eye out for, because the data is still tending to favor the use of PA catheters for the right patient.
That makes sense. I would end because we're at 1, but the last question came from Dr. Goldschlager, so I have to do it. So Nora asked, who tends to survive to discharge and what are their characteristics?
Oh man, that is a tough question. We have had every spectrum, everything. For this part of the data is so challenging is if you have a bad complication or a stroke and somebody who's otherwise supposed to do well, then they should have done well, but the device didn't work well in their body. And we've also had patients where everybody thought they would pass away, where Chris and I hand off to each other and like, this is a tough situation, and we say challenge accepted to each other, and at the end of the week that person's trached walking around the ICU, and we give each other a hard time about that. But it's a good point of saying that, you never know. So like, that's why you do daily assessments. You make sure that you're working within certain accepted bounds that are data driven, and make sure you're making good decisions as much as you can. And having, in Chris's point, the palliative care conversations when you need to.
Yeah, I think the large published trials and series, certainly comorbidities, advanced stage frailty, a lot of these factors are poor prognostic markers. But as Connor said, one of the problems in cardiogenic shock is we don't have good prognostic modeling, and that's an area of active research of how we identify patients who are going to benefit most.
Thank you both for a very exciting and interesting talk, and sort of an area that's being transformed very quickly. And thank you both for the work you're doing here to do that for us, and also very importantly to train all of us about this new and exciting area. Really appreciate it. Stay well. Talk to you next week.